Emily, I'll turn the floor over to you to kick things off.
Wonderful, thank you. Welcome everyone to today's program, and thank you so much for waiting. My name is Emily Rapley, and I am a writer with Becker's Healthcare. Today's program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will also receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter, Matthew Milliron. Mr. Milliron is a director in the Healthcare Appraisers Colorado office. His practice at Healthcare Appraisers focuses on the analysis of healthcare provider compensation relationships and business valuations. Mr. Milliron brings more than 10 years of healthcare industry experience, including hospital service line planning, hospital physician alignment, and payer strategy. Prior to joining Healthcare Appraisers, Mr. Milliron was a segment controller at Cigna Healthcare, where he was responsible for operating expense accounting, management reporting, and non-medical pricing. He began his healthcare career as an associate with Metametrics Group, where he worked on a variety of healthcare engagements, focusing on hospital physician integration and health system strategic planning. It is now my pleasure to turn over the floor to Matthew to begin today's presentation.
Thanks, Emily, for the introduction, and thanks to everybody for joining today. Sorry for the initial technical difficulties, but I think we got everything squared away. You know, when the folks at Becker's asked us for a topic for today's discussion, I was initially leaning towards something related to the development of value-based compensation plans. It's certainly a topic of the day. But as I stepped back and I thought about the compensation arrangements that have come across my desk over the last few years, I've noticed a couple things. The first is that the vast majority of these compensation plans are still volume driven. And the second is that nearly every proposal starts off using a compensation rate that is at or around the median, whether it's median annual compensation or median compensation per work RVU, et cetera. And so I started asking myself, you know, how did we get into a situation where the median is now perceived as the floor in physician compensation negotiations? Does this really make sense? And statistically, no, it doesn't. And in many cases, financially, it might not make sense either. This is probably a bit of an exaggeration, but physician compensation has become a little bit like tech stocks in the late 90s, in that values are on the rise, but these values seem to be tied less and less to the fundamentals of the practice itself. So I thought it would be helpful and interesting to have a discussion about median compensation, including some perspectives on the court's perceptions regarding median compensation, and also provide some insight into the survey data that many of you on the call use on a regular basis. So I guess the first thing that I'd like to do is get the statistical primer out of the way. So the dictionary defines the median as the middle value in a series of ascending values. And so when you're looking at survey data, this means that half of the respondents reported amounts that were less than this amount, and half of the respondents reported amounts that were higher than this median amount. And then as discussed, as defined in physician compensation negotiations, the median has become synonymous with the minimum or the floor for purposes of negotiation. So let's talk a little bit about some of the regulatory issues that are in play when it comes to healthcare transactions. As a general rule in healthcare, any transaction between potential referral sources is going to need to be both commercially reasonable and also at compensation terms that are consistent with fair market value. And as it relates to determining fair market value, we have been provided with some guidance. First is that we should avoid market values that reflect transactions between parties who are in a referral relationship. And the second is that we should avoid valuation methods that may take into account strategic value. An example of that would be incorporating the advantages of 340B drug pricing into the valuation of a private medical oncology practice. So what is fair market value? I'll spare you reading through the CMS definition, but to paraphrase, fair market value is the compensation that would exchange hands between parties who are not otherwise in a position to generate business for one another. So in other words, what is this service worth absent any consideration of patient referrals? And the other buzzword is commercially reasonable. So what does it mean to be commercially reasonable? Again, to paraphrase, would the parties enter into this arrangement if there were no potential referrals between those parties? So there are several very important regulations that determine what can and can't be done in a healthcare transaction. As a disclaimer, I'm not an attorney. I have never been an attorney, and I don't really want to be an attorney, but I think it does make sense to spend a couple minutes reviewing these for context. The first one is the Anti-Kickback Statute, and generally it prohibits paying for or attempting to pay for referrals. There are various safe harbors to the Anti-Kickback Statute, and many of these require that the compensation is consistent with fair market value. The Stark Law. The Stark Law says that if a physician has a financial relationship with an entity, then the physician may not make a referral to that entity unless a Stark exception applies. And these exceptions do include personal services and employment, provided that the arrangement is commercially reasonable and the compensation under that arrangement is consistent with fair market value. So we've established that fair market value is important in healthcare transactions. The question is, who decides what is fair market value? Unfortunately, or fortunately for people in my line of work, there is really no clear authoritative fair market value standard or a threshold that currently exists for fair market for physician compensation. CMS has provided some guidance that indicates that it believes external valuations are advised but not required. The use of available survey data is a good practice to employ. The necessary justification for fair market value is going to vary from arrangement to arrangement, and that different services will have different values. In other words, opportunity cost does not establish the value of all physician time. Now, as many of you on the front lines know, it can be very difficult to apply the fair market value standards in practice. There's often a lot of pressure to get the deal done, no matter what it takes. Physicians will review the survey data, they will retain consultants, and they often have a number that is locked in before your negotiations begin. And many times negotiating leverage can be lopsided when you have a service line that may be dependent on key people. The other thing that makes it difficult is that hospitals face a lot of competition for physician talent, and your competitors may not require an independent fair market value analysis, which puts you in a disadvantaged position relative to what other facilities may be offering. And I guess finally, the definition of fair market value requires that the compensation reflects the result of bargaining between parties who are not otherwise in a position to generate business for one another. We all know that the survey data contains responses from folks who are in that referral position. And so does this in some way prohibit the use of the majority of the survey data that is published? While no firm regulatory thresholds currently exist, CMS and the courts have provided some insight over the years into what they believe constitutes fair market value compensation. And the purpose of today's presentation is not necessarily to discuss all of the details of these laws and cases, but I'd like to touch on some key indicators of what the government has looked at in assessing fair market value compensation in the past. So Stark Phase 2, back in 1993, defined a couple different safe harbor approaches to determining fair market value hourly compensation to physicians. And one of these safe harbor hourly rates was established by dividing the average of the median annual compensation values reported by several national surveys by a denominator of 2,000 annual hours. I think that this was probably the most definitive guidance that has ever been provided. Unfortunately, this guidance was rescinded with Stark Phase 3. However, in Stark Phase 3, CMS did note that the reference to multiple objective, independently published surveys remains a prudent practice in determining fair market value. So this would support the notion that even though the surveys do report data from parties in a referral relationship, the government still thinks it's reasonable to use this data. In Toomey in 2012, the government's expert witness report suggested that physician compensation in excess of the 75th percentile is a reasonable threshold for Stark scrutiny. And in the Halifax case a year later, the government's expert witness stated that supportable compensation per work RVU ratios are typically at the median and in certain circumstances can move up to the 75th percentile if it's supported by the facts and circumstances of the arrangement. Now we have the more recent Citizens Medical Center case in Victoria, Texas, which was settled before trial, but some of the court's commentary on the case was somewhat shocking. Specifically, the court indicated that the existence of material financial losses on a cardiology practice allowed for an inference that the physicians were being compensated improperly, even if the physician's compensation was below median levels. So we'll talk a little bit more about that. And for each of these cases, it's important to note that there were, in many cases, numerous allegations in play, and the court's decisions didn't necessarily hinge on one specific item, but some of the guidance that's been provided over the years is helpful in evaluating what these regulatory bodies believe constitutes fair market value compensation. So let's dig into the details of the Citizens case a little more. As we do so, it's important to note that the case was settled before trial, so there is a lot that we don't know about the situation. Among various allegations, the relators alleged that 3 employed cardiologists' combined salaries increased from $630,000 in 2006 up to $4 million in 2007. And 2007 is the year that these employment arrangements began. If you divide those by those amounts by the 3 physicians, this equates to $467,000 per physician in 2007, while the MGMA median during that time was $485,000 per physician per year. And at the same time that the physicians were receiving a healthy compensation increase, the cardiologist practice was incurring material losses. And these losses were alleged to be $400,000 in 2008 and $1 million in 2009. So in the court's memorandum, the judge stated the following. Even if the cardiologists were making less than the national median salary for their profession, the allegations that they began making substantially more money once they were employed by citizens is sufficient to allow an inference that they were receiving improper remuneration. Now that's very interesting to me. At the end of the day, citizens settled for $21.75 million plus legal fees, and since the case was settled, we really have no determination of liability and no conclusive finding that operating at economic loss or material compensation increases are a basis for Stark or anti-kickback liability. As mentioned, there were numerous allegations in the citizens case that involved approximately 24 physicians in 6 different specialties. However, the case does raise some legitimate concerns. The first is that there's increased scrutiny of the economics of these compensation arrangements versus establishing threshold guidance. In this case, the threshold for intervention was fairly low. Whether it hinged on the cardiologist or whether there was something else going on, the cardiologists were making less than the median annual compensation. There was also quite a bit of attention paid to the sustained practice losses and the commercial reasonableness of these losses. And next, the fact that post-employment compensation increases may be problematic. So the argument that a physician was earning below market compensation prior to the employment arrangement might be wearing a little bit thin. And finally, kind of defaulting to median rates as an internal safe harbor may not be a safe practice anymore, given some of the other items we've discussed. So at the end of the day, the 3 plaintiffs each received almost $2 million for their efforts. And as we think about that, I mean, let's talk about the financial incentives that are in place for whistleblowers. Most of this is going to be familiar to the folks on the call. But in 2015, the government recovered almost $2 billion from healthcare fraud and abuse cases. And of these recoveries, $330 million went to the whistleblowers. This represents recoveries from just a single year. As many of you know, the whistleblowers may receive 15 to 30% of the government's recoveries under the False Claims Act. To date, this has resulted in payments to the whistleblowers of over $5.2 billion. And the really scary thing is that anybody can be in a whistleblower situation. You can have it, other physicians, employees of the health system, attorneys, consultants, and these they don't need sophisticated knowledge of healthcare law or valuation to file a suit. Oftentimes, the safest option for the defendant is going to be to settle the case rather than go to trial. In the case of citizens, they estimated that the potential liability, if they were to go to trial, would be between $300 and $400 million. So here's a little quiz. So which one of the following establishes fair market value? The fact that the proposed compensation was the best outcome that I could negotiate, that it was the equivalent to what the competing hospital across town is offering, that it is less than what we are currently paying a locums agency, or that it is equivalent to median compensation for my region. And then we have all of or none of the above. Now this is kind of a trick question. In practice, we've seen all of these used to justify compensation proposals as being consistent with fair market value. The truth is that in isolation, none of these necessarily will establish fair market value, but maybe in combination, all of them might. As discussed earlier, based on guidance from CMS, the documentation to support a determination of fair market value is going to vary based upon the facts and circumstances of the arrangement. So let's discuss some common approaches to determining fair market value compensation. The first that I'm going to go through, and the primary topic of today's discussion, is the market approach. In a nutshell, the market approach answers the question of what are other people paying or earning for similar services? And when applied to physician compensation valuation, the market approach is usually based upon data that is published in well-known market surveys that you all are familiar with. So what do we like about the market approach? The obvious answer is that in many cases you can find a lot of data that pertains to the specialty in question. And the second thing about the market approach that a lot of people like is that it's relatively easy. And you'll notice that word is in quotations. I think that the market approach is very easy for people to utilize. Everybody who has bought or sold a house is somewhat familiar with the principles of a market approach. But while it's relatively easy to pull a list of comparable sales in your neighborhood, it can be quite a bit more challenging to identify market data that is really representative of the service arrangement that you are trying to value. So let's discuss some of the drawbacks of using the market approach. The first is, you'll get what I'll call an off-the-rack conclusion that might not necessarily fit your arrangement without some adjustments. The next concern is that the respondents to the surveys might not be representative of your practice. The majority of the respondents to AMGA and MGMA are going to be large multi-specialty and single specialty practices who may have very different reimbursement leverage or ancillary capabilities that is impacting physician compensation levels. Another thing to consider is that loan groups are making up an increasing percentage of the respondent base. Why is this potentially problematic? The survey's data may be less representative of what physicians are able to earn based upon the financial performance of their practices. The next drawback is that the market data can be used incorrectly if it's not well understood. We see arrangements all the time where somebody is proposing to pay 75th percentile compensation per work RVU to a physician who is producing 75th work RVUs. Not necessarily a good thing to do. Another drawback is that although it's the best data that we have access to, the survey data is typically over a year old before it's published. And so what does this mean? What it means is that the data might not reflect known changes in the reimbursement environment. As an example, we have the temporary federal support of state Medicaid programs that help to boost primary care compensation levels. And while we know this funding has been made, it is not yet reflected in the market data. Moving on, clients often rely on regional data, believing it to be more representative of their specific market. The problem with using regional data is that the sample sizes can be very small, and this can result in significant shifts from year to year. And on the topic of regional data, you might also be looking at data that actually contains very few respondents from your state or your local market. And finally, the survey data is somewhat fluctuating. As we think about the median becoming the negotiating floor, the median continues to increase year over year. So let's talk about another common valuation approach for physician compensation, the income approach. And the income approach really answers the question of what are the normalized distributable earnings this arrangement or this entity will generate. So what are some of the benefits of using an income approach? The first is that as opposed to the off-the-rack market approach solution, it can really provide a more tailored conclusion regarding your subject arrangement. It generally results in a conclusion that's supportable in light of the practice's financials, and this can assist in supporting the overall commercial reasonableness of an arrangement. And it can also take into account known changes in the reimbursement environment and other trends that you may be aware of. Downsides to the income approach include the fact that it is more time-consuming, which can lead to higher costs if you're using outside consultants. There are times when it's going to result in lower fair market value indications than you would get from relying on a market approach. Certain attorneys have some discomfort using an income approach due to the treatment of in-office ancillaries, and the concern there is, does assigning value to this ancillary revenue stream directly or indirectly assign specific value to DHS referrals? There also may be instances when a practice simply can't be self-sustaining based upon the market dynamics. You may have a required specialty in a rural market where the patient demand is never going to result in enough revenue and income from the practice to support market level compensation for the physician. And finally, the use of an income approach may result in a situation where you have two physicians in the same general location that are earning very different compensation amounts for very similar services. While this might make sense for different physician owner-operators, it's a more difficult situation for a larger system that may want to standardize its compensation across a number of practices. So getting back to the market approach, let's talk a little bit about the specific data that is collected by the surveys. As it relates to the compensation and production data, the surveys will typically collect total cash compensation from all sources. This is going to include compensation for clinical services, call coverage, medical director services, any ancillary margins, ownership distributions, basically anything that would show up on the physician's W-2 or K-1 is going to be reported as compensation into the surveys. From a production standpoint, they're going to collect collections from the professional component of the services rendered, and also total work relative value units or work RVUs. And the surveyors then take this information and they calculate various compensation ratios, specifically compensation as a percentage of collections and also compensation per work RVU. And so what are some of the things that we notice as we look at the data that's reported by the surveys? One thing is that physicians at the lower end of the annual production spectrum tend to drive the highest compensation per work RVU rates. In other words, as aggregate production increases, compensation per work RVU, as reported by the surveys, tends to decrease. And the question is, well, why is this the case? And one very good reason for this is that many lower producing physicians tend to be on salary guarantees. And so the effective compensation per work RVU tends to be relatively high for those physicians. And so what does this mean in the context of compensation plan design? I think it means that it's really worth considering the expected aggregate production of that physician when you select the compensation rate to build into that plan. The following slide, this slide presents a graph that demonstrates this declining trend. Many of you are probably familiar with similar depictions. What this shows is the median compensation rates within each reported quartile of production. And this graph shows a sample of a dozen specialties, and the trend is fairly consistent for all of them. So just for fun, I thought that I'd show a similar graph, but instead graphing collections per work RVU by quartile of production. And as you can see, there's quite a bit less variability among these collections rates at different quartiles than you see with the compensation rates, with the obvious exception of interventional radiology. I'm not exactly sure what is going on there. But these two graphs would seem to support the conclusion that this declining compensation per work RVU trend is primarily a byproduct of the survey data, where you have compensation plans that are not necessarily tied to production driving up the comp per work RVU rate, as opposed to some conclusion that highly productive physicians are somehow generating materially less revenue per work RVU. A lot of clients, compensation analysts, are familiar with the concept of percentile matching. So in other words, a physician's annual compensation should be well matched to his or her annual production relative to the survey data. Please remember, this does not mean that you match the compensation per unit of production at that percentile to the physician's total production at that percentile. For those of you who have seen our presentations before, you're probably familiar with similar examples, but here is one for orthopedic surgery. If you take the 90th percentile work RVUs, multiply this amount by 90th percentile compensation per work RVU, you get an amount that exceeds the 90th percentile annual compensation amount by almost 50%. While this example should be fairly obvious, even median compensation rates can lead to a disconnect from a percentile match conclusion at high levels of production. As we'll see in the following examples, this isn't always going to be the case. There are certain specialties and situations where it'll work fine, but blindly defaulting to median rates can be problematic in certain instances. So let me spend a few moments just orienting you to these graphs that we're going to run through. The vertical axis presents annual compensation, and the horizontal axis presents annual work RVU production. The blue line is a percentile match trend line, and the red line is annual compensation calculated using the median compensation rate for the subject specialty. And all of this data is from MGMA, by the way, just to keep it simple. As you can see here for internal medicine, the median rate results in compensation that is well matched to production across a broad range of production levels. In fact, the median trend line below the percentile match trend line for a good portion of the production spectrum. When we look at non-invasive cardiology, the compensation is well matched to production until we get up to about the 75th percentile, where the median rate starts to significantly exceed a percentile matched value. In this case, if the median rate is applied to 90th percentile work RVUs, it results in annual compensation that's equivalent to 150% or 115% of the 90th percentile. For cardiovascular surgery, we have a similar situation. A median rate applied to 90th percentile work RVUs gets us annual compensation that's equivalent to 112% of the 90th percentile. This next example is for emergency medicine. And I recently reviewed an emergency medicine proposal that was entirely production-based, which is very rare for emergency medicine. And it proposed a compensation rate that was approximately 105% of the median. This may not always present an issue, but the group had several physicians that were generating work RVUs that were well in excess of the 90th percentile. And as you can see here, using a median rate 90th percentile work RVUs result in annual compensation that is equivalent to 116% of the 90th percentile. And this last one is just kind of for fun, since it's very rare to see compensation for trauma surgeons weighted heavily towards production. But in this case, 90th percentile work RVUs and a median rate results in annual compensation that is 137% of the 90th percentile. So I guess the question is, what does all this mean? When does compensation at the median tend to work well? The median tends to work fairly well for physicians who produce at or around the median. And for the majority of the examples we just took a look at, compensation really begins to pull away from a percentile matched value, if that's your objective, when production starts to exceed that median level. It also tends to work well when you don't have multiple compensation elements in the agreement that may lead to a total cash compensation per work RVU rate that significantly exceeds the intended production compensation rate, and we'll talk a little bit about that in a minute. The median rate tends to work well when the data from multiple surveys is fairly well in sync and in line with the other values. It can be helpful to review multiple surveys to evaluate whether the survey you may be relying on is an outlier, and maybe consider making some adjustments as a result of that. The median rate tends to work well for specialties that commonly use production-based compensation models. As we saw in the previous example, emergency medicine and trauma surgery produce the most variability from a percentile matched conclusion at high levels of production, and these are very often shift-based specialties. And finally, the median is going to work the best when the other facts and circumstances of the arrangement support the proposal from a commercial reasonableness perspective. If the median is going to result in material losses to the practice, then you should be able to present the business case for incurring these losses. So when does the median not work well? I'm not going to go through all of these because they're essentially the opposite of the ones that we just went through. So it tends to not work well in situations that are the opposite of those that we just described. So we've talked a little bit about stacking concerns when you're looking at the market data. Many of you know it seems that physicians are being compensated for more and more activities than ever. While value-based models are gaining some traction in certain markets, production-based models do remain kind of the prevailing model for the time being. And these plans usually consist of a base salary, production-based incentive compensation beyond a certain threshold, and any of a variety of other potential compensation elements, including quality-based compensation, co-management compensation, on-call compensation, compensation for various administrative services, whether it's medical directors or just committee participation, that kind of thing. You have compensation for outreach services, mid-level provider supervision stipends, research compensation, and on and on. You also might have any number of one-time payments that might be provided at the outset of the agreement, which would include signing bonuses, commencement bonuses, student loan assistance, so on and so on. So why is this necessarily a concern? It's important to remember that the compensation data reported by the surveys is going to include compensation from all sources. So there's no such thing as a clinical compensation per work RVU rate or a production-based compensation per work RVU rate that is reported by these surveys. The compensation is and so if you're using a median compensation rate as the production compensation metric and then stacking other compensation elements on top of this rate, it's really not difficult to achieve total cash compensation per work RVU that exceeds the 75th percentile of the reported values. So here's a simple example using the specialty of OBGYN. You have a physician who's generating median work RVUs and is compensated at a median compensation per work RVU rate. You have the physician receiving compensation for call coverage, which is equivalent to the median amount reported by MGMA. You have the physician serving in a medical director capacity, working 20 hours a month and receiving median hourly compensation as reported by IHS. And you have worked in a quality bonus of $20,000 a year and also a mid-level supervision stipend of $20,000 per year. Now, once you add all this up, you get to an annual compensation amount of $454,000 a year. And then when you divide this amount by the physician's actual work RVU production, the total cash comp per work RVU is approaching the 80th percentile. Whether this is a problem is really going to depend on your circumstances, but I think it's important to keep this issue in mind when you are developing physician compensation plans. So what are some steps that we can take to address the effects of stacking and lend further support to the commercial reasonableness of an arrangement? I think first, do your best to ensure that the various services provided under an agreement are mutually exclusive. For example, a physician should not necessarily be earning additional medical director compensation for administrative work that's performed during normal clinic hours unless compensation is entirely production driven. Mid-level supervision compensation has been gaining in popularity in my experience. I think it's important to make sure that this additional compensation is reasonable. If you have a situation where the physician's on a gig salary and the physician's providing mid-level supervision duties, are you really already compensating the physician for this supervision time in the form of their base? Regarding the call coverage, try to require a certain number of uncompensated call shifts. And when evaluating the commercial reasonableness of an arrangement, assess whether a single physician can actually do everything that's being asked. I'm going to, I know that we're running out of time here. I'm going to skip over some of these. Really don't want to say too much more about the market approach as someone outside of the scope of today's discussion, but I would encourage that even if you're not going to rely upon the approach, that it is a useful exercise to develop a financial pro forma for the professional practice based upon your proposed compensation plan. I mean, the question is, how can you explain the commercial reasonableness of an arrangement if you don't understand whether you're going to lose money or not? A few comments on commercial reasonableness, because we are running out of time. The questions you should be asking yourself is, why do I need to employ this position or enter into this arrangement? Do the qualifications match my needs? Could the services be performed by someone with less training and presumably at lower cost than the individual that I'm proposing to perform the services? And if practice losses exist, are they justifiable? Would a hypothetical operator incur these same losses based upon the characteristics of your market? Let's see. As we've kind of discussed, there may be some good reasons why a practice might incur sustained financial losses. You might have a situation with a required specialty with low demand. The practice might have a poor payer mix that makes profitable operations impossible, or the losses might really be optic losses only, in that in-office ancillaries might be carved out and shifted to a different profit center. But I think in any situation, there are good reasons why a practice could incur these losses, but I would encourage you, if that applies to your situation, to thoroughly document the business case for those losses, and preferably not in a file with a combined P&L that considers the facility margins. So let's see. Just to kind of wrap up, the point of today's webinar is not that median compensation rates are always problematic or even likely to be problematic. Whether the median is going to work for you is really going to be dependent on your particular situation. But I would caution against blindly defaulting to median compensation rates. I think you need to be aware of the effects of stacking. You might find yourself in a situation where the median is really resulting in something much more than that. And no matter what anybody says, the median is not the floor. There are many physicians, half of them to be exact, who are earning less than the median. So compensation amounts that are below the median may be appropriate based upon your particular circumstances. So with that, I'll hand it back over to Emily, who can open up the discussion for questions.
Excellent. Thank you. Thank you, Matthew, for a very informative and enjoyable presentation. We will now begin today's Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Matt will attempt to answer as many questions as he can during the time we have remaining. So, Matt, for our first question, we have an audience member who would like to know, why would it be a problem to pay two physicians in the same market differently if the two physicians are not equally efficient in use of resources? If they practice differently, why should they not be paid differently?
I think that's a fantastic question. It's a legitimate question. I think that you could make the argument that if the income approach would provide different conclusions based upon the expense side of the situation, as opposed to the revenue side. I mean, I think that physicians, it makes sense to reward the efficient utilization of resources and perhaps penalize the inefficient utilization of resources. But I think at the same time, if you are a large health system that wants to build its primary care network and have everybody on the same compensation per work RVU rate, there are many advantages to having a standardized compensation plan. I think to potentially penalize a physician that is in a less desirable location from a payer mix standpoint might run counter to the health system's objective of providing care to the community, kind of regardless of their ability to pay. So I think that whether that makes sense is going to really depend from situation to situation. But there are I think there are some legitimate arguments that if two physicians are working across the street from one another, working for the same system, and they have vastly different payer mixes, should one physician necessarily be penalized for that?
Perfect. Thank you. For our next question, when, if ever, is it reasonable to cite the compensation of other professionals, for example, lawyers, management consultants, etc., as references when considering compensation for physicians who will provide services that are similar in nature to those that the other professionals provide to a hospital?
Wow, another good thing. I don't know of any other industries where there is as much regulatory focus on ensuring that compensation is fair market value, and it's really a byproduct of the regulatory environment as opposed to being able to compare the professional services of a physician, which are heavily regulated, to the professional services of an attorney that doesn't have those same regulatory constraints.
Excellent, thank you. So for our next question, an audience member would like to know if administrative compensation that is not at risk, so hourly compensation, is excluded from the compensation work RVU rates.
As it's reported by the surveys, no. So the surveys will collect total compensation from all sources, which would include any medical director stipends that may be paid on an annual or hourly basis. So the total cash compensation that's reported by the surveys is an all-in number.
Perfect, thank you. Next question. Don't the surveys also reflect income from ancillaries? If so, why isn't the regulatory risk of ancillaries being included in compensation also a problem for the market approach?
I think that it is. I think that we don't necessarily have the ability to look at the survey data and make those adjustments. Any adjustment that we made for ancillary income or even ownership distributions, which is really kind of more a reflection of the business risk that physicians are taking that they aren't necessarily incurring in an employment situation. We just don't have the granularity of the data to make those adjustments, and so the concerns are there. I think that in my experience, folks are able to get more comfortable with that because you are not specifically looking at this ancillary income stream and assigning specific value to that income stream as opposed to relying on market data that may include some ancillary income. Certain practices may not have a lot of ancillary income. It's a little bit more indirect than when you use the income approach.
Sure, that makes a lot of sense. Okay, so we have time for one more question today.
Okay.
Matt, an audience member would like to know, do you typically prefer trying to match the work RVU percentile to the total cash compensation percentile? If not, what approach do you typically like to start with?
So do we typically like to match the total cash compensation percentile to the work RVU, the annual work RVU percentile?
Yes, that's correct.
Not necessarily. I think what we look for is reasonableness in terms of addressing some of those stacking concerns. For example, are there sufficient safeguards in place to conclude that the physician's compensation from clinical services is going to be based upon time that's separate and distinct from the time that they might devote to administrative services. I think that if you can make an argument that a physician is a full-time clinician, and on top of those full-time duties, they are also providing some medical directorship duties that are above and beyond those full-time duties. I don't necessarily have a problem with kind of stacking that on top of a conclusion for their professional services that we've reached, saying, okay, I do like to match the professional production with the compensation from their clinical services, and then based upon the circumstances of the arrangement, determine whether or not it's reasonable to layer on additional compensation on top of that fair market value clinical compensation determination. So you don't necessarily have to have a one-to-one match in terms of total cash comp, but what we do want to see is that the appropriate safeguards are in place to make sure that there's not a duplication of compensation for the same duties or the same time the physician's devoting.
Excellent, thank you. That's all the time we have today for questions. So Matt, I just want to say thank you again. That was an excellent presentation. And to our audience members, thank you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.